Susanna Spence. I'm also, as I said, from UT Houston. And we're going to switch gears now. We're going to talk about acetabular fractures. And really, most of this talk is aimed at those who truly, inexplicably, don't actually like acetabular fractures very much. So we're going to see if we can't break them down into something a little bit easier to understand so that you can feel a little bit more comfortable. I tend to be text light on my slides, but I've added some extra text on some of the slides so that hopefully it'll make it easier if you have to go back on your slides to review something. Okay, so I have nothing to disclose. So here are the objectives for today's talks. So we're going to talk about where the anterior and posterior columns of the acetabulum are, what the difference is between a column and a wall. We're going to overview the Judet-Letournel classification system, and then we're going to talk about actually the only 4 things you need to know about the Judet-Letournel system, and then we're going to use some routine CT images that you have every day for classifying those fractures. At the end, we'll have a little brief segment on some pitfalls and some ancillary findings. All right, so I said there was going to be 4 things that hopefully by the end of this talk you know about acetabular fractures. So here they are. By the end, I would like you to know what an acetabular wall is, what a column is, what a transverse fracture is, and how you would define a both column associated fracture. So let's get started. A little bit of background. We're going to talk about the function of the acetabular columns. It's really just part of a system that's going to transfer your weight from your spine through to the lower extremities. So I've got to have a few gratuitous 3D images in any lecture, right? So as we go through here, we're going to rotate this person here, but this is really just so you can get your orientation of what part of the pelvis we're going to be looking at. We're going to be looking at the pelvis from this kind of medial view right here. And so as we think about that weight coming from the lumbar spine, it's going to get transferred to the first 3 sacral segments because those are the ones that articulate through your sacroiliac ligaments with the adjacent pelvis. So the weight is going to be transferred to those first 3 sacral segments and from there to the sciatic buttress. Now, this is not a concept that we use much in radiology. We don't talk about the sciatic buttress much, but I do want you to keep it in mind for this talk because you are going to need this concept of the sciatic buttress later. From the sciatic buttress, then, the weight is going to be transferred into the anterior and posterior columns, and from there into the lower extremity through the hip. So the columns themselves, here they are, I've shaded them, the anterior column in green and the posterior column in blue. So the anterior column is going to be the pubic body, superior pubic ramus, and this large portion of the anterior iliac wing. The posterior column is just the ischium, and it only actually involves a small portion of the ilium just up to here at the greater sciatic notch. All right, so if those are the columns, then what are the walls? It's just a projection from the anterior and posterior column, deepening the acetabular cup and providing some stability to the femoral head. If you think about this little golf ball on this golf tee, it's not very stable, right? But if we added something that looked a little bit like the walls of the acetabulum on there, it would be a lot more stable. It therefore makes sense then that if the walls are used to make the femoral head more stable, that if you break the walls, the femoral head becomes unstable. And I think I'm just going to leave this up for a little bit so you can think about this concept in relation to this patient. So this is a patient who got into a motor vehicle collision. Knee hit the dashboard, and so it dislocated that femoral head out the back. And as you can see, as the femoral head dislocated out the back, it just shredded that posterior wall of the acetabulum. And until that posterior wall is repaired, that femoral head is going to be unstable and can fall out again.